Good evening, everyone. I'm Dr. Marty Ross, and this is another Conversations with Marty Ross MD tonight. We're going to talk about Lyme disease here. No 2 weeks are ever the same because you create them with your questions. And as usual, I'm looking forward to seeing what you have in store for me tonight. For those of you that are new here, there's a couple ways you can participate. One is listen to the questions and the answers I give, and there's always some good learning that you can get from that. The other thing you can do is actually write a question to me. And the way you do that is over on the bottom of the right-hand side of your screen, there's a chat box, and you can write your question to me there too. The only thing I ask is that the questions are brief and that you do not click the enter key until you complete the whole question. Each time you click the enter key, it sends a separate question to me, and it gets very complicated on my side to follow. So I appreciate if you follow that. And then for those of you that are back here again, there's a lot of familiar names I'm seeing here, so I'm glad to see you keep returning and you're getting some benefit out of this too. So thank you for being back here again. For those of you that are here, know that I'm doing a recording tonight, and that during the recording, well, actually during the webinar, the recording is being made, and tomorrow morning I will send an edited version of that recording out that will have a brief synopsis of what we talked about tonight too. I would appreciate when you get that, if you would share that video and that email with other people so people can learn what we're doing here. And I'd also appreciate in the future when you get notices to sign up for these webinars that you forward those to other people as well too. I'm trying to reach and help as many people as possible, and you can help me do that. During the webinar tonight, I will be reading the questions out loud, but for those of you that are participating in the live version here, you'll actually be able to see those questions on your screen. For those of you that are listening in on the recorded version, unfortunately, you can't see the questions. It doesn't show up that way, okay? So that email that I'm talking about will come out tomorrow morning, somewhere hopefully by 9:30 in the morning. I usually get that done. Sometimes I get a little delayed with that, but usually that's the goal. And tomorrow morning's email too, you'll be able to sign up for the first set of webinars in 2022. So this is my last webinar for this year. And then in the first week of January, I should begin a series of 3 webinars that will make up the January series of Conversation with Marty Ross MD. All right. So without any further ado, let's get started. Oh, one more thing before I say that. I will not get through all the questions tonight. So many of you I know write questions. I try to get through as many as I can. So know that I am trying to do that. But as you'll see, there's a lot to discuss. So we'll do what we can. Okay. All right. So let's go ahead and get started with the first question here. Hello, Rich. Let's see. These webinars are amazing. They are greatly appreciated. You're welcome. Let's see. Can you herx when treating intestinal yeast? If so, can the herxing be as bad as what you can experience with Lyme? Is the yeast overgrowth normally in the small intestines, the large intestines? Also, can you tell us what percentage of your Lyme patients complain of weak legs? All right. So we got to answer all that for you. So about the weak legs, what percent of people? Well, I mean, everyone's got some degree of fatigue with Lyme. So if you mean that people just feel tired, probably about everyone. In terms of people describing like weak legs in the muscle or weak muscles in the legs, I don't know, maybe about 5%, maybe 10% have that as a specific complaint. I wouldn't call it a primary complaint that many people have, okay? In terms of intestinal yeast, so intestinal yeast most often are going to grow in the large intestines if they grow too much. So all of us have some amount of yeast, candida yeast, living in our intestines, okay? And those candida are kept in check by the healthy bacteria that live in the intestines too, so they don't overgrow. But if we do things in our life that tend to support growing too many yeast, we'll grow too many yeast. So some of the things that can lead to too many yeast are poor diet, being on steroids, sometimes being on birth control can be a setup for that, stress, and yes, antibiotics. Antibiotics are a big cause that can lead to imbalance of the good bacteria, and then you can get yeast overgrowing. Now, generally, when we talk about intestinal yeast overgrowth, we're talking about the large intestines. There is a condition which is known as small intestine bacterial overgrowth that has which is an overgrowth of germs in the small intestines. Your small intestines aren't supposed to have many germs there, okay? But some people get germs that work their way up from the large intestines into the small intestines. And if it's bacteria, we call that SIBO. If it is yeast, we call that SIFO, small intestine fungal overgrowth, okay? So yeah, yeast can be in the small intestines, but usually when we're talking about intestinal yeast overgrowth, we're talking the large intestines, okay? All right, so can you herx? Yeah, you can get some huge herxes from treating yeast. In fact, if I've got somebody that has a large degree of intestinal yeast, I usually will not even start antibiotics at a first visit. If I think clinically it looks like they've got a large amount of intestinal yeast in their intestines, I'm going to treat that alone. And I may even start with just nystatin alone and then gradually add in after a week diflucan. So nystatin is weaker than one of the stronger agents I like to use, which is diflucan, fluconazole. So I'll start with the weak one first to knock down some of the germs. And then after a week or so, I'll add in the bazooka, which is a diflucan. All right. That diflucan nystatin combination is something that can take about 30 days to wipe out yeast, and it's about 90% effective. Okay. So that is one option. I'll show you a paper I've written here in a minute about, or an article I've written about how do you treat yeast, which gives you other options in addition to using the nystatin diflucan that I just mentioned. Okay. Now, so yeah, you can get herxes, and so the immune system will see the dead yeast parts. And what a herx is the same thing that can happen with Lyme, and when you kill tick infection. So the immune system can see the dead germs, and it reacts by making more inflammation chemicals, which are called cytokines. Now, keep in mind, when you have Lyme symptoms, and when you have mold symptoms, mold toxin symptoms, and when you have yeast overgrowth symptoms, there's actually a common thread in all of those symptoms. All of those conditions trigger your white blood cells to manufacture cytokines, okay? And cytokines are good and bad. On the good side, cytokines are what the white blood cells use to communicate to other parts of the immune system to turn on to fight that thing, okay? And so increased cytokines cause more white blood cells to be made, help draw them to where the infection or toxin is, and they help those white blood cells work better. So that's all good. But if the immune system is having a hard time dealing with that infection or that toxin or that yeast, it's going to try harder and harder, and eventually it's going to make too many cytokines. And too many cytokines make it so you can't think, give you fatigue, disturb your sleep, make you hurt all over, interfere with your hormonal function. I mean, I can keep going down the list of what we call Lyme symptoms. Guess what they are? They're mainly excess cytokine symptoms, okay? So now when you start killing germs and the immune system sees more dead germ parts, it's going to react by making more cytokines. So your underlying symptoms that are part of your Lyme or your yeast or your mold toxin illness are going to get worse. Okay, that's what happens. That's what a Herxheimer is. So yeah, it definitely can happen when you have too many yeast. To prevent that from happening or to deal with it, I use the same approaches I use to manage cytokines and herxes in Lyme infection. And that is my number one go-to herb to help manage and prevent Herxheimer reactions is curcumin. Curcumin is a component of turmeric, the Indian seasoning turmeric. It gets inside of white blood cells and limits their production of cytokines. The product I like for that is a product made by Thorne called Mariva 500. It's a liposomal form of curcumin. I like using a liposomal form because it increases the absorption of curcumin into your bloodstream, okay? The second thing I'll do if it's really severe is I'll have people take liposomal glutathione. Glutathione is a very strong antioxidant that is made in every one of our cells to help repair damage to cells. It's also used by the liver to actually help with detox, okay? But the reason I use glutathione with a herx or to manage cytokines is white blood cells have to be told to make cytokines. And one of the signals that tells them to make cytokines is having an excess amount of oxidizing agents that the immune system makes when it's attacking something, all right? So you can lower those oxidation signals by being on glutathione. So the product I like for that is a product made by Research Nutritionals called Trifortify. The reason I like the Trifortify product is the way that Research Nutritionals has manufactured this product. They manufactured it for great absorption, all right? And in fact, they have great studies showing it's well absorbed, probably better than most other glutathione products that are out there, all right? In That's why I recommend it. And when I have people take the Tri-Fortify, you can either get a Tri-Fortify orange or a Tri-Fortify watermelon, and you would do a teaspoonful one time a day. Okay, so let me show you a few articles here. Do a screen share. Okay, so, oops, what's that? Okay, so this is my Lyme disease information site, Treat Lyme by Marty Ross MD. In terms of reading about yeast, this is my yeast section. And in terms of what you use to get rid of yeast, the various options you have, I lay them out here in my article called Kills Yeast, a Brief Guide, okay? If you're trying to determine if you have too many yeast, take a look at this article called A Silent Problem, Is It Yeast? And there's even a questionnaire in here that you can use that helps you determine if you have too many yeast, all right? Then in terms of cytokines and what do you do to manage them, take a look at my section called Herxheimer and Cytokines. Okay, the main article is this one called Control Cytokines, a Guide to Fix Lyme Symptoms in the Immune System. This is where I describe cytokines and tell you what things to take on an ongoing basis to limit cytokine production, okay? Over here, this article called Herxheimer Die-Off Reaction, Inflammation Run Amok is an offshoot of this article, but it kind of describes to you what do you do when you actually are having a Herx reaction, okay? So take a look at both of those articles. All right, thanks, Rich. Good luck to you. All right. Hello, David. Let's see. Hi, Dr. Ross. Do you treat patients differently for mold toxicity if they do not have a gallbladder, or is the treatment the same? Any additional supplements that should be added for these patients? Also, would you recommend treating mold toxicity first, get it under control, then proceed forward getting the COVID vaccine or getting the vaccine as soon as possible? I'm concerned of getting double cytokine storm at the same time. Thanks. All right. So in terms of, so gallbladder, everyone, is an organ that sits attached to the liver, okay? And when the liver processes toxins, like mold toxins, that it doesn't handle well, but it still processes them, the first place that they get moved into is into the gallbladder, and then eventually they go from the gallbladder out through the bile duct out into the intestines, all right? So if you've had your gallbladder removed, you don't have a place that stores these toxins. They just, in that situation, they more continuously drain out into the intestines versus if you have a gallbladder, they tend to get stored there. And every time you eat, the gallbladder contracts and squirts them out into the intestines. Okay, that's the difference. Does that change how I approach treating a person? No. So let me just talk briefly about that. So when you have what mold toxicity illness is a condition that occurs in 25% of all people if they have Lyme and don't have Lyme. And 25% of people have a genetic predisposition where they can build up mold toxins, okay? So what happens in 75% of people is we breathe in a mold toxin from the world around us. It gets absorbed through our lungs into the bloodstream. And once those toxins are in the blood, some of our white blood cells will see them and tag them, okay? So they're the white blood cells that tag things, basically, right? So once they've been tagged, then other white blood cells will come in and break down those mold toxins so we never have a problem with them. All right. So that's what's supposed to happen. What happens, though, with people that have mold toxicity illness is about 25% of people are genetically programmed so that their immune systems don't tag the mold toxins. And if they don't get tagged, they don't get broken down by the immune system. So these untagged mold toxins go to the liver, which is supposed to clean out fat-based toxins like mold toxins, but the liver doesn't handle them well either. And the liver's job is what it's supposed to do is transform these fat-based toxins by adding a water-soluble group onto them so that they will then mix in our poop and we poop them out. That's what's supposed to happen. But that doesn't happen, okay? So they go to the liver fat-based, they come out fat-based. They get moved through the bile system, sometimes stored in the gallbladder, but if you don't have a gallbladder, they still get moved out through the bile system, out into the intestines. And because they're fat-based, they get reabsorbed back into the bloodstream. So you just get this endless loop going on, okay? So the way that you treat mold toxin illness is to take binders, things that bind fat-based toxins, so that you can grab hold of these mold toxins out in the intestines, and those binders would hold on to them, and you'd eventually poop them out. Okay, so that's what is supposed to happen. All right, so any of the binders still work in this situation, whether you have a gallbladder or not. I don't change which binders I use. I choose my binders based on what the profile is of the mold toxins that a person has. Okay, let's see here. Oh, and then in terms of your second part of your question, so my advice to my patients when that have Lyme and or mold toxicity illness is, because COVID can kill you, and because COVID can leave you with long haul syndrome that may continue to contribute to your ongoing fatigue, brain fog, etc., I do recommend that people get the vaccine as a priority. All right, especially with the Omicron virus starting to surge, and we probably are going to be seeing just a wave of COVID hitting the States here soon, especially in those parts of the country where they don't believe in masking and where they don't believe in doing vaccines. So those places are just going to get screwed coming up, to be honest with you. And I'll be quite candid with you. So I do recommend getting the vaccine. In terms of what I see in my patients that have mold toxicity illness or Lyme, I see that they handle the vaccine the same way that people that don't have these illnesses handle it. Rarely there are complications, but that's rare. The major thing that people will see with the vaccine or getting boosters is that the vaccine does trigger a temporary cytokine surge. So usually over the course of a few days, maybe even up to 2 weeks, most people that get these vaccines in a booster will have some increased fatigue, brain fog, maybe even flu-like symptoms, okay? But generally those pass. It's a rare person that has complications that persist after a week or 2 week period from getting the COVID vaccine or getting the booster shots, all right? And when we come down to looking at what is the most effective way to prevent harm from COVID, it's the vaccine. I know there's people out there that seem to buy into this idea that ivermectin is the thing that can save things, which is a parasite killer that some people have been using to treat COVID and acute COVID. The problem with that is the science actually is not that clear as to whether it works, because most of the science saying ivermectin works is very poor quality. It's been subject to a lot of research bias in what they find, okay? Secondly, the problem is that we really don't know how effective it is at stopping or limiting people from getting hospitalizations. The only thing we know that works well, that is proven to work well at preventing bad illness and preventing hospitalizations in many, is the COVID vaccine, okay? Now, I got to admit, Omicron is a different animal, all right? And Omicron seems to be overrunning even the vaccine, but what does seem to hold promise is if you can get fully vaccinated and get your boosters, there is a good chance that that will prevent hospitalization and even getting the illness, okay? So I'm advocating quite strongly that people get it, okay? Now, you anti-vaxxers out there, you've come after me before for saying this. I stand by what I'm saying. This vaccine is a safe vaccine. It is not causing undue harm to people that have Lyme. In fact, LymeDisease.org has done a study looking at how people with Lyme handle the vaccine versus people that don't have Lyme, and it's all the same. People with Lyme have the same outcomes on the vaccine that people without Lyme. Okay, so I stand by it quite strongly, actually. So anyhow, I would do that, and then eventually, once you're if you do flare up, then with my patients in a similar situation as yours, I would recommend they start doing their mold toxin treatment after that. Okay, the mold toxins you can get to when you get to, but if you get COVID, especially with this Omicron coming on, you could face some dire consequences from that. Okay, all right. Good luck to you, David. Hello, Jim. Hi, Dr. Ross. I have what seems to be Lyme-associated arthritis, like pain in my right elbow and forearm. How would you suggest dealing with this? Also, is Voltaren pain cream a better choice than NSAIDs like Tylenol? Thanks. So, Jim, the first thing I would do is treat your infections. I mean, because getting the infections under control with either herbal or prescription antibiotics will help. Okay, so keep in mind that the prescription antibiotics especially have anti-inflammatory properties. So you like your tetracyclines and even your macrolides like clarithromycin, azithromycin, your tetracyclines being doxycycline, minocycline, in addition to killing germs, also have some anti-inflammatory effects in the joints, okay? The second thing I do is then with my patients is to get them started on anti-cytokine, anti-inflammatory cytokine herbs. So I mentioned those earlier tonight, but the two main ones I would put somebody on would be curcumin, 500 milligrams as the liposomal curcumin, that Thorne product, they call Mariva 500, one pill 3 times a day. And I might also put a person on the liposomal glutathione that I talked about. If that does not help well enough, my second line would be to consider using a medication that is helpful in Lyme in terms of making your intracellular antibiotics like the tetracyclines and the macrolides work more effectively. That's a medication called Plaquenil, which is a quinine medicine. It's originally designed to actually help with malaria. Doesn't do a good job with that. But it's been repurposed by rheumatologists because it's been discovered to be a really good anti-inflammatory at partially lowering cytokines, but also lowering other inflammatory chemicals that are seen in arthritic type conditions. And that's a 200 milligram twice a day. The reason it also is used in Lyme is that we think that Lyme, intracellular Lyme that lives inside of cells, sometimes can be in part of cells which are called vacuoles or caves, okay? And inside those caves, the Lyme germs create a very acidic environment that could and can potentially deactivate the effectiveness of your intracellular antibiotics like the tetracyclines and the macrolides, okay? So Plaquenil makes those vacuoles more basic or more alkaline. And that can help your intracellular antibiotics work better too. Finally, some of my patients do get some benefit using the Voltaren and the non-steroidal anti-inflammatory creams. That's a reasonable thing to look at doing as well too. Okay? All right. Good luck to you, Jim. All right, let's see here. Hello, Mosby. Let's see. Itchy small spores that come and go, especially along the spine. Any thoughts? No, I would need to ask you a lot more questions and I would need to see them. I'm sorry. I just don't have a better answer for you than that. Okay? All right. Good luck to you, Mosby. Hello, Dave. Let's see. In a recent email, you mentioned that you like to use IGeneX for tick-borne disease testing. You mentioned using IGeneX to test for 5 different things: Lyme, Bartonella, Babesia, Ehrlichia, and Anaplasma. Does IGeneX have a test for mycoplasma? Can you explain why mycoplasma is and is different from Anaplasma? Also, is mycoplasma a common co-infection that should also be treated if you have been diagnosed with Lyme? Okay, so let me address that. So IGeneX has testing for Lyme, Bartonella, Babesia, Ehrlichia, and Anaplasma. And that's what you mentioned there, and they do have good testing for that. I am not aware that IGeneX has testing for mycoplasma, okay? But I'm not a strong proponent in treating mycoplasma. Now, I know some of my colleagues treat for it, but hear me out. So first of all, if you happen to have mycoplasma, the same antibiotics that we use to treat intracellular infections like Lyme, the intracellular kind of Lyme, and also Bartonella, the antibiotics we use to treat Bartonella and intracellular Lyme take care of mycoplasma, okay? So even if I don't intentionally treat it, I probably am treating it because my treatments often deal with both of those infections, all right? But also, I'm not a big believer that it is a problem. So if you were to pull 100 healthy people off the street and you were to test them to see if their immune systems have made antibodies against various infections, you would find evidence in about 20 to 30% of them that their immune systems have made antibodies against Epstein-Barr virus, which is the monovirus, cytomegalovirus, human herpes virus type 6, and human herpes virus type 8. Those are not sexual herpes. Those are respiratory herpes viruses. And you would find evidence that they have antibodies against mycoplasma pneumoniae and something called chlamydia pneumoniae. Okay, so mycoplasma pneumoniae and chlamydia pneumoniae are two bacteria that are common in healthy people. Remember, I said that if you test healthy people, you will find elevated antibodies against these infections. Okay, so just having evidence of antibodies against these germs does not mean they're harming you. All right, because our immune systems are designed to keep those germs under control. We can cohabitate with germs inside our cells the same way we cohabitate with germs on our skin. All right, we're capable of doing that. Now, it is possible when your immune system is dealing with Lyme and co-infections that the mycoplasma it's been dealing with will get out of control. However, we have no way of knowing that. So measuring elevated antibodies does not tell you whether the immune system still has it under control or it got out of control. All right. So my philosophy on the mycoplasmas and the chlamydias is treat Lyme, treat your tick-borne infections, get the immune system to start working better by doing that. And it can step in and take care of the viruses I mentioned, as well as chlamydia pneumoniae, as well as mycoplasma pneumoniae. Okay. Now, there is one form of mycoplasma that may be transmitted by ticks. It's something called mycoplasma fermentans. I don't specifically test for it. And the reason I don't, again, is anything I'm going to use to treat intracellular Lyme, which would be the tetracyclines and the macrolides, is going to take care of mycoplasma fermentans. Okay. So that's my philosophy on it. Okay. All right. Good luck to you, Dave. So for those of you that want to read a little bit more about what I was just telling Dave, let me take a look over here. Okay, so I have an article I've written called Target Viruses, Mycoplasma, and Chlamydia and Lyme. Maybe not, all right? And this is basically what I was just explaining. You can take a look at why I say that here in this article, okay? Hello, Kate. Let's see. Dr. Ross, thanks so much for hosting tonight. You're welcome. Question number 1, can LDN actually increase thyroid antibodies? For some reason, mine went up 300 to 500. I take 4.5 milligrams of, I think you mean of the LDN, and I felt relatively the same on all doses I was on, the 1.53 and 4.5 milligram doses. And now I'm worried it's having the opposite effect, stimulating my thyroid. Is that even realistic? Number 2, does low-dose naltrexone raise cortisol? My endocrinologist is claiming it does, and that's why my cortisol and free total testosterone are elevated. If not low-dose naltrexone, what could cause these to elevate? Could thyroid cause it? For what it's worth, I've had acute Lyme in 2020, and I don't have symptoms anymore, but I still love learning from you. Thanks so much for all you do. You're welcome, Kate. So, everyone, naltrexone, low-dose naltrexone and naltrexone. Naltrexone is a drug that is used to treat narcotic overdose. Okay, that's what it's manufactured for. Basically, it binds to narcotic receptors in our body. When people are overdosed on their morphine, basically it knocks the morphine off of those receptors, and so it binds to those receptors. Okay, now, we have our own natural narcotic system in our body, which are called endorphins. We manufacture endorphins to help manage pain, but we also make endorphins to regulate the immune system. And if we temporarily block our endorphin receptors with naltrexone, which binds to those receptors too, if we temporarily block that for like 4 to 6 hours, which is what naltrexone at 1.5 up to 4.5 milligrams does, if we temporarily block it, what happens is the brain sends out a bunch of signals to the endorphin producing cells in the body and says, make more endorphins. Okay, so they do. And the second thing that happens is those endorphin receptors start becoming extra sensitive to endorphins while they're under blockade. Okay, so when the blockade wears off at about 6 hours after you took your dose, these endorphin receptors are more sensitive to any endorphins out there, and the body has made excessive amounts of endorphins, so they get, so these, there's a super response to the endorphins, basically, okay? These endorphins have a way of regulating the immune system to downturn autoimmune illness, all right? And so it can often be helpful in autoimmune illnesses like Hashimoto's thyroiditis. I have to be honest with you, that's a paradoxical reaction you had. I use it often for my patients with Hashimoto's, Kate, and I've never seen an elevated TPO occur from using it, okay? I am not sure as to whether it does affect cortisol. I haven't seen that happen to my patients before, nor am I aware of any science supporting that. So I would ask that your endocrinologist shares with you some science on that, because I'm not aware of it. I'm not saying it can't happen. I haven't seen it happen, nor am I aware of it happening even with testosterone either. Okay. So ask him, can you show me the science on that? Because I'm not aware of that. Okay. All right. And then, keep in mind, I have a rule in medicine. And so, first of all, I would, before being fully certain that the LDN has led to increase in your TPO, the one thing I want to make you aware of is that ultimately it can take about 6 months to get a full effect of your low-dose naltrexone. Okay. So if you had just recently started it and they've measured, and it hasn't been 6 months, and you've gone back and you've measured your TPO and it's up, it could just be that it's gone up naturally because the LDN has not had enough time to work. Okay, so that's one thought. Okay, and I have no idea how long you've been on it and how often you're getting tested on your TPOs. Okay. Second thought I want to let you be aware of is that, and this is a common thought I have in medicine in general, which is, this is my statement on medicine as side effects. Okay, so my rule of thumb, the Dr. Marty Ross rule, is that anything can happen to anyone with anything. Okay, what I mean is, there's the common side effects we all know about with different drugs, like low-dose naltrexone can make it hard to sleep. We know about that one, okay? But anything can happen to anyone means that maybe it can trigger high TPO. It could, okay? Because we all are very unique laboratories. Each one of us is individualistically different than the other human laboratory beside us, and drugs behave differently in each one of us, all right? So it's possible it could have, but I don't know if I would write it off yet. I would probably want to recheck again. If you were my patient, I might recheck in about 2 months, 3 months, and just see, is it still going up or is it coming back down? Okay, all right. I think I answered everything there. Yeah, all right. Good luck to you, Kate. Thanks for that question. One thing I want to do real quick, I'm going to do another screen share here. So for those of you that are not familiar with low-dose naltrexone and need more information about when you take it and how you take it and how you start it and what dose do you work up to, etc., take a look at my article here called Low-Dose Naltrexone, LDN and Lyme, okay? Keep in mind, a general time frame that you need to give low-dose naltrexone to see if it's going to work is about 6 months. It takes time to see what the full effect of this is going to be. All right. Oh, I see. Kate, it looks like he asked your question twice in 2 different places. Let me get rid of that one. All right, this next question is from Julia. Hi, Julia. Let's see. Hello, Dr. Ross. Do you do mycotoxin testing for all of your patients, or is there any testing you do for all of your patients? Also, will successfully treating main infection make other co-infections more symptomatic, like a guacamole effect? Also, do you see SIBO or gut infection resolve with treating BART and tick infections? All right. But there's a lot of questions there. So first of all, I know a number of my colleagues will do what I call take the gunshot approach when they test. They will do many different tests and panels to test for every type of tick infection, and they'll measure cytokines. They'll do your toxin testing. They'll get your gut workup all at the same time. Okay, I don't do that. I really try to talk to my patients and figure out what testing do I need to help me figure out what I want to do with them. At a minimum, if I've got somebody that has a tick-borne infection, I will get at least the Lyme immunoblot through IGeneX and see if that's positive as a means of giving me evidence that they've had a tick-borne infection. I will then ask them a lot of questions to see if they have symptoms that are also consistent with symptoms I'd see for Babesia and symptoms I will see for Bartonella. If they have a lot of symptoms of Babesia or a lot of symptoms of Bartonella, I often will treat for those infections without testing, although I always give the option of testing to my patients, okay? I will usually start there. Now, there are times I might come back and do mold toxin testing up front too. But generally, I'm going to not do mold toxin testing until somebody is about 6 months into treatment, and I will only do it if we're not getting better, because the majority of people with Lyme do not have mold toxin illnesses, okay? The people that I start wondering about mold toxin illnesses are the people that give me at the beginning of treatment, not at 6 months, but at the beginning, are the people that when I'm taking my history, I ask them, have you ever been in buildings where you knew there was mold? And if they say yes, then I ask them, and in that building, is that where you got sick? And if they say yes, I say, okay, we're going to do mold toxin testing. Because it's also very possible that you can have mold toxins and you have positive Lyme testing, but your major problem wasn't the Lyme, it's actually the mold toxins, okay? So it's very tricky to figure out what's the most important thing to do, but I try to take a detailed history so I can see if the history tells me what I should test for based on symptoms, and also what I should treat based on symptoms, and whether I need to initially test for mold toxins or can I wait till about 6 months and 6 to 9 months, and if somebody's not getting better, then I might consider doing my mold toxin studies, okay? In terms of SIBO and gut infections, I don't test for any of those up front. The one gut infection that I will look at from a symptom standpoint is to see if at the beginning of treatment does somebody have intestinal yeast overgrowth. And the reason I consider if they have intestinal yeast overgrowth is, number one, severe intestinal yeast overgrowth can look and create a syndrome that looks just like Lyme disease, okay? Because again, too many yeast in the intestines trigger too many cytokines. Too many cytokines give you symptoms of Lyme disease, okay? Same symptoms, okay? And then and how I make my decision to treat is based upon the outcome of my yeast screening questionnaire. And if somebody on my yeast screening questionnaire determined they have yeast scores over 140, I usually find some benefit in treating for yeast, okay? So earlier tonight, I showed you my yeast section at my Treat Lyme by Marty Ross MD site. If you click on the article, which was about how do you, it's called Yeast, a Silent Infection. If you click on that, in there is the screening tool that I just mentioned, okay? You want to do that and fill that out, okay? Now, I want to give you a story about how significant mold and or Lyme, yeast and or Lyme can be, all right? So 2 stories. Number one, about 2 years ago now, I had a woman that came to see me from Indiana. I'm out here in Washington State, but at the time, this is pre-pandemic. Believe it, there were days before the pandemic. And she came, actually, she grew up in Indiana. She was now living down in Oregon. And she came in, she had a clear story of having Lyme disease. She had a bullseye rash, got bit by a tick, had all the symptoms that looked like Lyme. But what threw me when she came through the front door is she was just loaded with acne on her face. I mean, just severe acne. And she's like mid-20s, all right? Mid-20-year-olds shouldn't be having severe acne. And so severe acne sometimes is a clue that you have intestinal yeast overgrowth, all right? So when you get yeast in the intestines, release toxins that get into the bloodstream, and in some people interact with the skin and give bad acne, right? So she also had a very high yeast screening score. So after our first visit, we did get Lyme testing. I was pretty sure she had Lyme because she had a tick bite and bullseye rash, okay? But we did Lyme testing. And while we waited for that to come back, I treated her yeast, put her on diflucan and nystatin, put her on some anti-cytokine agents, that Thorn-Meriva 500, and put her on probiotics. By the time she came back to me, she was 90% well. She initially came in, I think her energy was like 2 out of 10. By the time she came back, she was like 8 to 9 out of 10, okay? We treated yeast an additional month, and after that month, she was 100% well, All right. I didn't even do anything with her Lyme, because it's also possible when you get Lyme, your immune system deals with it. All right. So in her case, it wasn't Lyme disease she had, although she had a lot of symptoms of Lyme. It was yeast overgrowth syndrome triggering excessive cytokines. Okay. So that's one story why I say yeast are an important thing to consider. Okay. All right. Second story, mycotoxins. I've had patients that have come in, clear history of having a tick bite and bullseye rash and getting sick, or having symptoms consistent with Lyme. But the story they gave me as I took my detailed history is they really were doing well, pretty well in life, not having any problems. And then suddenly, this one person, for instance, had lost his wife, lost his kids, lost his job, lost everything because he was too fatigued and had severe cognitive impairment, so he was no longer able to function. His mom, who was a nurse, brought him into me because she was very concerned about him. And they had been told by one of my local colleagues here that his brain was so infected with Lyme that he had to fly off to GemSec and get his IV antibiotics. Okay. And I took his story, and he had a positive Lyme test and he had symptoms that looked like Lyme. But when I got to the part about tell me where you've lived and whether you got sick in any of your homes, he was living in a home that had black mold on the walls when he got sick. That's where he got sick. Okay. So the history was obvious that I had to look at black mold. And when we got the mold toxin studies back, they were just sky high. All right. So all I did with him was about 3 to 4 months of binders, and he was 100% well. And I never did anything to treat his Lyme because, again, he had positive testing, but I think his immune system dealt with it. Okay. So you've got to let the history guide you in this illness as to what is the greater likelihood of happening, the thing that's triggering your cytokines, and go after that, basically. Okay. All right. In terms of SIBO, basically my approach with gut is if you're gassy and bloated, go after yeast first. If that doesn't take care of the gassiness and bloatedness, then I will probably get a SIBO breath test, a test that looks to see, you swallow some sugar water and you breathe into these tubes and you send it off to the lab. And if you're blowing out excessive amounts of methane and hydrogen, that means you've got SIBO. Okay. All right. Thanks for the question, Julia. Good luck to you. Hello, Alex. Hi, Dr. Ross. My doctor prescribed Ivermectin 3 milligram tablets and instructed me to take 5 pills at one time once a day. That seems high. Is that the correct dosage? I have to go back and look on that one. Let's go look together. So first of all, I'm not sure what he's using it for, whether he's trying to use it as a supposed treatment for actually as a real treatment for parasites. That's what it's supposed to be used for. Or is he one of the people that thinks that ivermectin is actually useful for COVID? Okay. But the starting, regardless of what you're using it for, it's a standard dose. And let's look it up together here. I'm just blanking on it right now off the top of my head. So let me go to do a screen share here. Okay, so in terms of how you use it, if you are going to use it, and again, I'm not a big advocate for ivermectin, but I will say there is a chance it could help. The greater chance that something helps is actually is the vaccine. We know the vaccine does work. Okay, where's my ivermectin dosing here? Oh, that's not it. Let's see. I'm getting to it here. I've got it somewhere in this article. Okay. So a dosage of ivermectin is 150 to 200 micrograms per kilogram. Okay. And let's see, you're 190 pounds, I believe. So bear with me here for just a minute. So to find out kilograms, you take your pounds and you divide it by 2.2. So 190 pounds divided by 2.2 equals, you're an 86 kilogram person. And we're going to take that times 150 micrograms. And that equals, yeah, he's a little bit high. You would be needing about 12 grams, which would be, well, on the low side, at the 150 micrograms, you would need 12.9 grams, okay? And at 200 micrograms, let's see, I got to go back here. All right, so I have to go back. All right, so let's see, clear that. 190 divided by 2.2 equals 86 kilograms times 200, 17, 16. So you could take anywhere from about 13 to 17 milligrams, okay? So what did he do with you? Let's go back here and see. Yeah, that's a correct dose. That is in the dosage range that you would want to do for your size, okay? Whether you're using it for parasites or on the possibility that it might help with COVID. And I said possible might help with COVID. I'm not a big believer in that, okay? Anyhow, but that is a reasonable dose, okay? All right. Thanks for that question, Alex. All right, let's see here. Hello, Amanda. Let's see. As always, thank you. You're welcome. Let's see. I am suffering from mold, and I wonder now, where is the best place to live? I wonder this because many places in California have moisture mold issues. Should I, and is it best to move to a warmer, drier climate until we at least heal, or would this be a forever challenge? Boy, that's without knowing your full story, Amanda, that's hard for me to say. Most people that I treat with mold toxicity illness do not need to take the extreme situation of moving and uprooting everything to go to a super dry climate. They just don't, okay? And frankly, even in dry climates, mold can be there as well too, although it's going to have less of a chance. So you may have less of a chance down in Arizona or New Mexico, for instance, and maybe in dry parts of Colorado than you might up here in the Pacific Northwest. But generally, in my practice, I'm able to get people well even up here, okay? All right. I would need to know more about your history to tell you one way or another. All right. Good luck to you, Amanda. Hello, Carter. Let's see. Yellow oozing blemishes that show up. Is that a secondary staph or strep infection? I don't know. I would need to take a look at it and see. And I would need a lot more history than that, Carter. Thank you. Good luck to you. Talk to your doctor about that, okay? Hello, Lewis. Let's see. What infections really go after the eyes? And are there any that like to go after the vocal cords? My voice is wispy and weak. All right. So in terms of vision disturbances that people can get with Lyme, and in terms of voice disturbances, we have to think about neurologic involvement, meaning the nerves that make the vocal cords work, or the nerves that either make the muscles that move the eyes work, or the muscles that make your lens change shape, or the optic nerve at the back of your eyeball. What can infect all of those nerves can either be Bartonella or Lyme. Those Bartonella or Borrelia. Those would be the main two I would think of. Okay. All right. Good luck to you. Hello, Amanda, again. Happy holidays to you. You're amazing, and we are all thankful. Thank you. I appreciate that. And happy holidays to everyone here, too. As many of you know, this is the last one until the new year. So I would have wished you holidays at the end, but now that Amanda brought it up, I'll say it now. I'll probably say it at the end, too. Anyhow, thank you, Amanda. Hello, Justin. Let's see. Which bugs cause degenerative joint disease? So degenerative joint disease, everyone, means that the cartilage that covers your bone and joint. So in a joint, you've got two bones that come together, okay? The covering of those bones is cartilage. Cartilage is softer than the bone it covers, and it's smooth. And its job is to act as a shock absorber, okay? And to allow bones to glide over each other smoothly. Now, the trouble is with that cartilage is it's soft and smooth. It's softer than the bone it covers. And in our most used joints, it can wear down on its own. So a big cause of degenerative joint disease is just wear and tear from your joints from living life, basically, okay? And especially as we get older, many of us, including me, are going to be subject to having some of those changes in our joints. And I already have some of those changes in one of my joints, my knee joint. Probably for me is because of years of running, basically. But it can happen. Some people are genetically more vulnerable to have degenerative joint disease than others, okay? So what happens is the cartilage wears down, you get bone rubbing on bone. And when bone rub on bone, it creates inflammation in the bone and you get thickening of the bone. Eventually, you can even get bone spurs, for instance, okay? All right. In terms of germs that can be involved in this, in terms of tick-borne infections that can be involved, the Lyme germ can be involved. And probably how it's involved is Lyme likes to live in areas of low oxygen in the body, all right? In fact, Lyme tries to quickly get out of the bloodstream and good oxygen flow and get into tissues of poor oxygen and blood flow, because oxygen in Lyme and blood can kill Lyme. All right, so it's designed to survive. It wants to survive, and it goes to tissues that have poor blood flow. So it goes to scars, gets into joints, gets into muscles and tendons, the coverings of muscles and tendons, gets into nerves, gets into places of poor blood flow. All right, now, what it likes to do is burrow into joints. So Lyme releases enzymes that can burrow deep into tissues, and therefore it can release enzymes that might break down cartilage. So it is possible with the Lyme infection that you might get a greater chance of having degeneration of the cartilage. My first approach to joint pain is try to get the inflammation under control. But let's say I'm getting Lyme under control as I look at all the other symptoms. Somebody's getting better with their thinking, their energy's improving, etc., but their joint pain isn't improving. That's when I'm going to start wondering, I wonder if I've got some degeneration in that joint. And what I might add into my treatment is something to help repair the cartilage, and that's to use a building block for cartilage, which is called glucosamine sulfate. Glucosamine sulfate is a 500 milligram pill. It's one of the building blocks for cartilage. And you take a 500 milligram pill 3 times a day, give it at least a 3-month trial to see if it's going to help. It does tend to work about 80-85% of the time. That's what my experience says, okay? If you're going to try it, make sure you're using a high quality product. There is just a lot of garbage glucosamine and even chondroitin sulfate out there. You don't need the chondroitin. You just need glucosamine sulfate. I suggest to my patients that they try the Thorne product, Thorne glucosamine sulfate. I trust Thorne. Thorne does a good job of sourcing for quality materials in their product and not putting garbage in their product. And so I usually recommend the Thorne glucosamine sulfate 500 milligrams 3 times a day for at least 3 months to see if it's going to make a difference. But I don't even think about doing that until we're further in treatment. Somebody's improving, but it's the joints that are not improving and the joint pain. Then I might start thinking about degenerative disease there. Okay? All right. Thanks for the question, Justin, and good luck to you. Hello, Brandy. Let's see. Buzzing, vibrating feeling in my core spine. Could this be tick infections? So that buzzing and vibrating is a neurologic symptom. I tend to see that as part of Bartonella. It is possible Lyme could be a factor in that too. To see if you have Bartonella, take a look at the article I've written on Bartonella where I list out a lot of symptoms you might get with Bartonella. If you have a number of those symptoms, then you might think you have Bartonella. Okay, let me show you that article here. All right, so I have a section here called How to Diagnose. And then here's my article on how to diagnose Bartonella. Okay, so I walk you through what the symptoms would be, and I do some discussion of testing. I need to update this. So the testing I have in here right now is more to do a Galaxy PCR test. But as many of you know, I'm also now endorsing as the better way of screening for Bartonella to do the immunoblot test for Bartonella from IGeneX. I think it's a better test, actually. Okay? All right. Good luck to you, Brandy. Hello, Sharon. Let's see. Hi, Dr. Marty. Thank you for answering our questions. You're welcome. In your Bartonella treatment guide, the Tier 1 approach is proposed combining various antibiotics with minocycline or doxycycline, but not with tetracycline. Why is tetracycline not used in these Bartonella combinations? Good question. So you could use tetracycline. The reason I didn't include it in there is it's hard to come by. You would think tetracycline, being one of the oldest antibiotics that we have, is actually hard to find. And sometimes pharmacies don't have it. Manufacturers periodically don't make it. So the main reason I did that is your more accessible versions of tetracyclines are the doxy and the minocycline. But you easily could do tetracycline if you can find it. That would be 500 milligrams 3 times a day, Sharon. All right. Good luck to you. Thanks for that question. Hello, Margaret Lee. Let's see. Can you comment on the reliability of IGeneX testing? Have you ever suspected a false positive? Can you make sense of IGeneX immunobot results positive for IgM but negative for IgG with both Lyme and Bartonella when the patient has had symptoms for at least a year? Positive IgM, negative IgG suggest acute recent infection only. Do Lyme and company not follow traditional IgM, IgG norms? Lyme immunobot positive IgM 3 bands, positive IgG negative, Bartonella, Henselae, and genus immunobot positive IgM, and negative IgG. That's a great question, Margaret Lee, and let me tell you what we know. So Lyme and Bartonella break the rules. I'll just start by saying that, okay? So it is possible. So Lyme, even though so everyone, let me start over again. So Margaret, you sound like you may be a healthcare provider here too. So if that's so, welcome here too. So anyhow, when we're doing with an immunoblot, we're measuring to see if you have made antibodies against these germs, whether it's Lyme or Bartonella, all right? And the immunoblot is just a method we use to see, do you have antibodies that attach to proteins of these various germs? When we have antibody reactions to infections, we have 2 primary ones. There's a family of antibodies called IgM, and there's a family of antibodies called IgG. What is supposed to happen is you develop IgMs first, so they're generally considered to be the acute antibody, and they are supposed to go away, and they get replaced by IgG. And on average, they go away somewhere around 6 weeks to 3 months into any infection, okay? Whether it's mycoplasma, Lyme, whatever it is, okay? Right now, it has been my observation for a number of years that about 50% of the people I'm diagnosing with chronic Lyme don't have IgGs, they have IgMs, even if they've been sick for years or more, okay? I see that. And, most doctors would want to call that a false positive test because that's not supposed to happen, all right? All right, so if we look at back in about 15 years ago, I think it's been over 15 years ago, the National Institutes of Health funded 3 studies looking at whether long-term antibiotics work for people that have chronic Lyme disease. And I believe in all 3 of those studies, people had to have been previously treated and failed standard treatment. And then they were enrolled in these studies based on whether they met CDC criterion for having Lyme disease. And so as part of the condition of trying to see if they could enroll in these is they had to fail treatment and they had to have a positive Western blot by CDC standards, okay? Now, evidently in that screening, when they screened for patients, they found in their screening that about 50% of people with chronic Lyme actually tested positive with IgMs. All right. So that was never published by them. I forget who did publish it, but that was based on their own data. So their own data says that 50% of people make IgMs and they don't convert, or they may still make IgMs and have IgGs. It can be either way. All right. We do not have a solidly good explanation for why that happens, other than it does happen. Okay. And in fact, if you, Brian Fallon, who is runs the Columbia research Lyme disease center, actually had a book out about Lyme disease. I think it came out about 2 or 3 years ago. Just write Brian Fallon, Fallon, and Lyme disease. You'll find his book. He even reported on it in that book. So if you're looking for citations about this, look at it. Okay. Now, he reported it. He doesn't always believe that it means it's true. Okay. On the other hand, I think IgMs, when they come back positive, even though somebody hasn't converted over, it just means they haven't converted. To me, it's evidence that they have had Lyme in them. There's a number of theories as to why it happens, but we don't have a solid idea as to why it happens. And so anyhow, yeah, it can happen. Okay. Then more recently, Burrascano gave a webinar on behalf of IGeneX, and maybe it was about 3 or 4 months ago now, on the IGeneX Bartonella immunoblot. And he was reporting that what they are also seeing is IgMs remaining positive even after somebody has had Bartonella for a long time. And so he's the first one to report that I'm aware of. I don't know to the degree that it actually happens, but I also, based on that, am not thinking of it as being false positive. I think it just explains something we don't understand, okay? Something that Lyme infection probably does within the germinal centers, maybe of the lymph nodes, making it so they don't convert over. That's one of the theories, actually. But there's something going on with these infections that's making it so that that it becomes arrested in terms of converting over to doing the IgGs. But generally, most of us that treat Lyme do not consider these to be false positives. There's something we don't understand. Okay? All right. Good luck to you, Margaret. Hello, Thomas. Can you explain Nagalase result numbers? What do the results mean as far as virus problem or not? Thanks. Okay. So Nagalase, everyone, is an enzyme that has an effect of deactivating a chemical called GCMAF. GCMAF stands for GC macrophage activating factor. Okay, so macrophages are a type of white blood cells that can fight cancer and they can fight viruses. And viruses make this chemical called Nagalase in their skin. And what it's supposed to do is break a sugar group off of this activating factor. And when it breaks the sugar group off the activating factor, macrophages don't get activated. Therefore, it's hard to get rid of chronic virus infections. Okay. Now, cancer cells can make this too, because macrophages also are involved in attacking cancer cells. Okay. So when it comes back elevated, you also need to consider, could there be cancer? But usually it's pretty clear by a history that somebody doesn't have cancer, okay? So the way I will use the Nagalase is when it comes to chronic viruses, I don't trust antibody testing. So I know my colleagues, many people will do antibody titers and see if you have elevated antibodies against a cytomegalovirus, Epstein-Barr virus, human herpes virus type 6, parvovirus, B19, all these different viruses. People will go out and study and see, do you have elevated antibodies? And they wrongly claim that if you have elevated antibodies, it must mean you need to treat the viruses, okay? And what I would argue is all that it means is your immune system is fighting the virus, and maybe it's keeping them under control, because all these viruses I just told you about, they're all common viruses in healthy people too, all right? So great, the immune system is doing what it's supposed to do. That's how I interpret high elevated antibody levels, okay? Likewise, it is possible if you have a virus that's just out of control and raging, it might suppress the immune system, and so you would have low antibody levels. And so some of my colleagues would say, you got low antibody levels, you don't have any virus problems, right? How can they say that? All right. What really matters is what's the virus load in you. All right. And for many of these viruses, we don't have a way of measuring the virus load. By comparison, for instance, in HIV treatment, not that this is HIV, but in HIV treatment, one of the things they measure is viral load. They can measure how much virus do you have in you. But all these chronic viruses that we have here, you can't tell, okay? So an indirect way of measuring viral load is to measure this chemical that viruses make called nagalase, all right? And the reason they make this nagalase, again, is to deactivate one of the white blood cells that can kill them, all right? So if you have elevated nagalase, it suggests you've got elevated virus load in the body. It doesn't tell you whether it's Epstein-Barr. It doesn't tell you whether it's human herpes virus type 6. It doesn't tell you whether it's parvovirus. It doesn't tell you whether it's the monovirus. It just says you got an elevated viral load, all right? So in that kind of a situation, the nagalase, I believe, is normal up to, it's supposed to be less than 0.95. I have found benefit in treating if people's nagalase is about 1.1 or higher. That's generally when I'm going to treat. And what I will do is I will put people on olive leaf extract, working up to 4,500 milligrams a day, divided into 3 doses. And I will also put, olive leaf extract is an herb that can kill a variety of viruses, okay? So it doesn't target any one, it kills all of them, all right? And then, or supports killing of all of them. And then the other thing I'll do is I'll put people on reishi mushrooms, because reishi are a group of mushrooms that turn on the antiviral part of the immune system too, okay? All right? And so I'll do that as a 400 milligram pill 3 times a day. I might also put somebody on a transfer factor mix, something called transfer factor plasmic, that has transfer factors in it that help the immune system target certain virus infections. And that's a product by Research Nutritionals called Transfer Factor Plasmic, 1 pill twice a day. All right. If you want to read more about this and these arguments I'm making and what to do if you have chronic virus load increases, take a look at my article. And so let me just do a quick screen share on that. All right. So let's just write the word viruses in here. So the article I've written about this is When and How to Treat Chronic Viruses in Lyme, a brief guide, okay? And I outline the nagalase testing idea. I outline why I don't trust the antibody levels, et cetera, and what to do if you happen to have high viral load, okay? All right. All right. Thanks for that question, Thomas. Let's see here. Hello, Mary. Let's see. Hi, Dr. Ross. Thank you again for setting up this seminar. You're welcome. How do you know if you have toxic overload? Is there a test? I have a long history of Lyme and co-infections plus MTHFR. I was recently treated with Malarone, Zithromax, and doxycycline with not much relief. I have taken Research Nutritionalist glutathione for months with little relief. You know, I would say there's certain toxins we can't test for, okay? So we can test for mold toxins, for instance, and you can do a real-time test, a urine mycotoxin test. Great Plains Lab runs a testing you can do to look and see if you have various environmental toxins, like a Roundup, for instance, okay, the weed killer Roundup. Do you have those and various types of plastics within your system, okay? But those are environmental toxins. In terms of xenotoxins, the kind that we make as part of our normal chemical reactions and killing germs, there is no testing I'm aware of that allows us to test for those things, okay, unfortunately. So there's not a good way of finding out. I mean, again, you can look at the environmental toxins. Great Plains has various ways of doing that. You can do mycotoxins, and I prefer real time for that. But beyond that, there really isn't a good way of knowing, unfortunately. The one comment I want to make about your MTHFR too is in terms of MTHFR, that stands for methyl tetrahydrofolate reductase, okay, MTHFR. That's an enzyme. And when people say they have MTHFR, what they're saying is their genetic profile is abnormal. They have abnormality in the C677T gene and or the A1298C gene that programs how the methytetrahydrofolate reductase is supposed to function. Okay, what that enzyme does is it helps convert diet folate into an activated folate called 5-methytetrahydrofolate, 5-MTHF. You want that 5-MTHF to be there because it's the beginning step in a series of detox reactions that results in glutathione, which is your master detox chemical, okay? Now, just having a genetic defect does not mean you manifest the problem, all right? So the blueprint may be wrong, the genetic code, but there's things the body can do to correct for that, including we carry around billions of bacteria in our gut, okay? And we're not giving them a free ride. So to put this in context, 90% of the genetic material that is found in our body is not us. It's from the germs that live in our intestines, 90%, okay? We're letting those germs live there for some reason. We're not just feeding them for no reason at all, right? So those germs, there's a lot of the research into the gut microbiome and what its purpose is just burgeoning in the last years. It's just it's going up exponentially, all right? And some of the things we know is that microbiome is good at detoxing. The microbiome makes chemicals that regulate how your brain works and how your mood is. The microbiome releases chemicals that regulate your immune system. Okay, those bacteria do something for us, all right? And it's possible those bacteria also make up for the things that we're not able to make ourselves. So it's possible they may make methytetrahydrofolate for us, all right? It's possible they may convert diet folate themselves to the methytetrahydrofolate we need, all right? So to see if you actually truly manifest a problem with blockage of that MTHFR, what I will wind up doing is measure homocysteine levels. And if you're not making enough 5-MTHF, you will wind up having elevated homocysteine. And I only treat for MTHFR if the homocysteine is elevated, okay? So you may want to go back and look at that as well too, all right? Thanks for the question. Good luck to you. Hello, Tim. Let's see. I recently saw a webinar with Dr. Horowitz and Dr. Cameron regarding the COVID vaccine in Lyme patients. Dr. Horowitz recommends taking 2,000 milligrams of glutathione half hour after getting the vaccine shot and 6 hours after that, while repeating the same dosages the following day to block inflammation. Also, he recommends starting curcumin, glutathione, C, D, zinc supplements a few weeks prior to the shot to shut down the inflammatory pathways. Any thoughts on this protocol? I'm really concerned about having a flare-up after taking the vaccine, especially the second shot. Thank you. So it used to be, and when in the first days of the vaccine, when we were all trying to figure out what this vaccine does and how people would react, I was not at that time recommending that people do anything to disturb their cytokines. All right. So keep in mind, when you get that shot, the immune system's first response to the vaccine is going to be to produce cytokines, inflammatory cytokines, okay? And that's actually a good thing. You want your immune system to make cytokines because those cytokines signal to the other parts of the immune system to develop immunity to that thing, okay? That's good. It's good. The trouble is what I started seeing is that people were having excessive cytokine reactions. And so I too now believe that people should do things to limit cytokines. My approach is to do curcumin beginning week, maybe even 2 weeks before you get the shot. And that's to do liposomal curcumin, that Thorn Meriva 500 milligrams 3 times a day. And I suggest that patients take 500 milligrams of glutathione orally, the liposomal glutathione, the kind that's well absorbed, like the Trifortify, twice a day. And that they continue it for maybe up to a week or 2 weeks after, however long it takes to get the inflammation to go down. That's what I've been doing. Horowitz just has another way of doing it. Horowitz is a big proponent in IV glutathione. I can't say whether his approach is any better than mine or mine is better than his. No one's done any head-to-head studies, but it's the same idea. Okay. All right. Thanks, Tim, for that question. Hello, Tim again. Let's see. Hi, doctor. Regarding mold toxicity, I see on your website that you recommend reaching to 3 pills a day of activated charcoal for black mold toxicity. Have you seen good results if you can only tolerate 2 pills a day instead of 3? Yeah. I mean, basically, take what you can tolerate. It may slow down how quickly you get those toxins out, but even a smaller amount will pull the toxins out. Okay? All right. Good luck, Tim. Let's see. Oh, I think we already answered this one earlier for you. Yep, we did. Hello, Adrian. Let's see. Hi, Dr. Ross. I was bit at 12 weeks, or I was bit at 12 with a bullseye. Hit with amoxicillin for 2 weeks, asymptomatic until age 28 when became debilitated. My number one Lyme symptom is severe abdominal pain, primarily in the lower abdomen, but my whole stomach hurts. I tried Phytostan GI and Capri Plus for 30 days, no difference. I also tried a product called Candida Support from Amazon for a few months with no improvement. I'm desperate for solutions and considering next trying prescription antifungals. I assume since I have chronic Lyme, it has to be Candida leaky gut, C. diff. What would you recommend to treat this symptom? Thank you for all you do. All right. So, Adrian, to give you the best advice, I would want to ask you a lot of questions. I'm going to throw out something, though. I wouldn't consider severe abdominal pain a normal symptom of the Lyme infection. We do know that Bartonella sometimes can give severe abdominal pain, and we think it has to do with Bartonella causing a lot of inflammation and swelling in the lymph nodes deep within the abdomen, and you get pain from that, okay? When somebody has severe abdominal pain like you're describing, I tend to want to do a workup to make sure it's not Lyme related. So for instance, if your pain is in the gallbladder area, I would want to do gallbladder studies. If your pain is in the stomach area, I might get my specialist to take a scope and scope down in your stomach and take a look at it. If your pain is deep in the abdomen, I might get ultrasounds of your pelvic area. Anyhow, I would need to ask you a lot more questions to try to figure this out, because I would not call severe abdominal pain something that is typical in Lyme. Okay. All right. So I talked to your doctor. They should be working you up like you don't have Lyme. So you can even go to your primary care doctor and say, I have severe abdominal pain. They should start going through a process to make sure it's not something besides Lyme. Okay. Should rule out everything else first before it's assuming it's part of Lyme or part of Bartonella. All right. All right. Good luck to you, Adrian. Hello, Denise. Let's see. I came out of remission after 6 years, 4 months after vaccine. It does show 2 IgM. The others are IgG. I don't believe I got rebit. Could the vaccine have deactivated the Lyme? The others. All right. So again, I would talk to you earlier tonight, or I talked to everyone earlier tonight. IgMs don't necessarily mean it's acute. Okay, they could mean chronic. The other thing is, this really gets tricky. It's hard to say whether you're out of remission from Lyme, or did the vaccine trigger an inflammatory reaction of excess cytokines that has yet to quiet down. That rarely can happen. Okay, so to give you the best advice, again, this is a situation where I would need to ask you a lot of questions to figure out, is this really Lyme, or is it that this is still an inflammatory reaction set off by having gotten the vaccine? Now, everyone, I still advocate getting the vaccine, because what Denise is describing is rare, but it is a rare thing that can happen. These kind of adverse outcomes that Denise is describing are far less of a chance of happening than getting COVID and dying from it. Okay, so I still recommend getting the COVID vaccine, although there is an occasional person that will have an adverse reaction to the vaccine. Okay, all right. Thanks for the question, Denise. All right, so hello, LM. Can you comment on the outcome of the disulfiram study at Columbia? I haven't seen that they have an outcome yet. The last I knew over a year ago is they were still enrolling people. I am doubtful they have finished their study yet. Maybe they haven't. I'm just not aware of it. But I haven't seen any data on that one yet, and I'm not aware that they have published any findings yet. Okay, all right. Thanks for that question. Hello, Vanessa. Do you also work with patients who have multiple chemical sensitivity? I do. I wouldn't call it my strongest suit. I mean, it is something I do manage as part of Lyme disease, but there are probably people, if that's your primary problem, that are probably more skilled at this than I am, okay? But thank you for asking, Vanessa. All right, let's see here. Hello, TJ. Let's see. Any foods to help gain or maintain weight? I can't tell if I'm absorbing or just burning it all off. Okay. So when it comes to foods to gain weight, we have to look at what your most calorie-dense foods are. Okay. So you have proteins, you have carbohydrates, and you have fats. All right. Proteins, and boy, I'd have to look this up, but fats are have more than double the amount of calories per gram than what protein and carbohydrates or sugar do. Okay. So when I'm wanting somebody to gain weight, I'm emphasizing fatty foods. All right. So that can be increasing the amount of nuts that you have, or having nut butters, or having cheeses, or having dairy that's rich in fat. It can mean using flaxseed oil. It can mean having lots of avocado. It can mean taking a tablespoon of flaxseed oil a day. I mean, it can mean all of those kinds of things. Coconut oil is a good source as well too. But emphasizing foods that are richer in fat, any fat source is going to be a better way of adding weight on than proteins or carbohydrates. Okay. All right. Good luck to you. Oh, TJ, and let me just say one other thing. So at my, just do a quick screen share. So on my my Lyme information site, there is a section I have here on nutrition. Here it is. All right. So if you want to know what healthy fats are, what kind of fats would be good to emphasize, take a look at my diet, which is it's a paleo, it's a healthier paleo diet. And in here, the sheets that show will have an area about fats, and there are healthier fats you want to emphasize. You can find a list here in this article. Okay. Hello, Paula. Let's see. Is stevia and claritin used anymore? Also, what is the best treatment for mast cell? And my doctor suggested peptides, L37 and thymosin-alpha-1. What are your thoughts on that? And also, I received horrible cat scratches and bites from an outside cat, and I'm wondering if that affected me. Also, have you ever thought of writing a new book with all of your new information? That would be great. Thank you very much. So I am going to be republishing my anti-germ action plans, because I clearly have done some updating on the Lyme treatments, the Bartonella treatments. I've got a few things to put into an update on my Babesia treatments, and I've redone my Lyme disease treatment protocol. And those were all big central parts of my anti-germ action plan. So partly what I'm doing, Paula, right now is rewriting those articles. Like you saw, I republished my the Ross Lyme support protocol, and you saw that I just released a new article on my updated antibiotic approach for Lyme. That's all laying the groundwork to turn this into a new anti-germ action plans book. Okay, so yeah, it's coming. It's a one step at a time, basically. In terms of cat scratches and bites, yeah, they could have. And it's possible that those cats could have given you Bartonella. Possible. Your doctors may want to test for that. In terms of the thymosin alpha-1 and the L37, they could give you some benefit. I don't know any more off the top of my head your specific situation, but yeah, those are things that might give benefit. And then in terms of treatments for mast cell, I think it's just best if I show you the article so you can read through it, okay? So I have an article on mast cell activation where I talk about both natural and prescription approaches. Let's go ahead and look at that together here. So take a look in my immune system section. Take a look at this article called Mast Cell Activation in Lyme. All right, and in here I describe what mast cell activation is. And anyhow, I talk about the major steps. One is decreased stress. So the hugest activator of your mast cells becoming supercharged and becoming allergic to everything is stress, okay? Get rid of the things you might be allergic to, treat infections that trigger the mast cells, remove toxins that trigger the mast cells, lower cytokines made by the mast cells, take things to limit the histamines, okay? And then stabilize your mast cells so they don't make as many. So quercetin and luteolin, for instance, okay? You might even consider a low histamine diet. So anyhow, this is my plans. I describe it, and then I kind of walk you through the different approaches. You could even show this to your doctor and see if they would help you implement it, okay? All right, so everyone, just real quickly. So mast cells are a type of cell that make histamines when we're allergic to something. And traditionally in medicine, we only thought the only thing that caused them to make histamines was things we were allergic to. However, we now know that those mast cells can be stimulated to be overreactive to things we're allergic to. And what stimulates them to be overreactive are infections like Lyme. Mold toxicity can be a big one. So we now know infections are a big cause. We also know that stress and anxiety are huge activators of the mast cells, okay? So one big thing we'll have people do if they have less stress and anxiety is try to bring that down. Often just bringing that down is a good step towards decreasing activation of your mast cells, okay? All right. Thanks for that question, Paul. All right, everyone. Look, we could go probably another 3 hours, at least another hour and a half. But you've had good questions tonight, and there's more here. But I need to wrap it up. I've got a couple of Basenjis that my dogs that need to get out for their evening walk. I've got to get out for my evening walk. So listen, everyone, I've had a great time being with you here tonight, and I will see you after the holidays. So I want to wish everyone happy holidays, whatever it is you celebrate. For me, I just celebrate solstice. I'm not into the religious holidays, but I will be celebrating solstice. To those of you that celebrate religious holidays, great. I hope they're wonderful for you as well, too. And to everyone, Happy New Year's as well, too. Okay. I look forward to seeing you in the new year. Keep your eyes open tomorrow morning at your mailbox for the email announcing that the recording is ready. And in that email, you'll be able to sign up for the January series of the webinars. And I would appreciate, again, if you would share these emails to those that you think will get benefit as well, too. Okay? All right. Good night, everyone.